So, good evening, all the aspirants present here. The topic for today is hematological management, and the faculty that we have here is Dr. Shraddha Patharkar, ma'am. She is the associate consultant at ABMH Hospital, Pune. Thank you, ma'am. You can start.
Okay. So last time I've gone through the same slides, but this time we'll discuss about each case. The case scenarios will be same only. So my first case is, can at least anybody read the case? Because this is slideshow mode only. For me, it is the full screen, the case is visible, but I don't know for the aspirants whether it is visible or not, because it's a big case. You need to read it.
Aspirants, this is going to be a very interactive session. You can unmute your mic and speak up. Thank you.
Can you
Yeah, it's
see my
visible.
slide?
It's
Yeah.
visible.
Okay. So the first case is 55-year-old female, known diabetic, hypertensive, ischemic heart disease, recent history of receiving painkillers for her backache and generalized weakness. She took some antibiotics also for her low-grade fever. She presented with GTCS one episode, followed by right-sided weakness, altered sensorium since a day. Uh, while arriving to ER, MRI stroke protocol was done for her, and it was normal. There was no bleed, no infarct. Labs suggestive, meanwhile, lab reports that we traced suggestive of platelets of 22,000, hemoglobin of 9, WBC was normal, mildly deranged LFTs were there, creatinine of 2, and we noticed hematuria after Foley's catheterization. Her fever profile was sent, which was negative for malaria and dengue, and the ANA by IFA, it was done from the outside, and that report was positive. ANA blot was sent. So all are false regarding the case except. So plasma exchange with FFP has mortality benefit in this case. Low platelets less than 30,000 favors the diagnosis of hemolytic uremic syndrome. Low Adams 13 level is a specific test to diagnose TTP, that is thrombocytopenic purpura. Mixing studies help establish the diagnosis of congenital TTP, and the classic pentad of TTP is present in almost half the cases. So, can anybody enumerate what are the abnormalities in this case and what can be the possible diagnosis? Once you conclude what it is, then only you can pick the right answer. Can anybody enumerate all the abnormalities in the case?
We can't see the slide which was described earlier.
Ma'am,
we see
this
only-
slide is different. What you are showing slide is different.
Yeah.
You are not able to see first slide. Yes, this is the first slide. Yeah.
I don't know why this.
It is not, ma'am, in the slideshow mode.
No, I mean it is in the slideshow, but it's with slideshow. I think nothing is visible, so I'm just zooming it out. Now, can you see the case at least? I don't know what is the problem. It's in the slideshare mode only. Can you read the case? Now, is it visible?
Yeah, it is visible now.
So, tell me the abnormalities, all the abnormalities. Lab abnormalities as well as clinically, which systems do you think is involved? So, she presented with
She has
GTCS.
Ma'am, it is
Yes,
hematological
GTCS.
system and renal
low
system.
Uh, please, can
She
anybody?
She presented with GTCS.
Yes.
Involved with low platelets, hemoglobin of 9,
Focal
and
neurodeficit is also there. GTCS with
yeah.
FND.
Deranged LFTs, and her renal profile also is abnormal, and with hematuria on catheterization. And she had her profile was sent for which were still pending.
Yeah, ANA is positive. So it's
ANA was
autoimmune.
positive.
Yeah, so that was done outside, and it indicates some autoimmune pathology that has
Yeah.
led to thrombocytopenia, altered sensorium, and AKI as well. So initially we thought of stroke, but that was ruled out on MRI. So what can be the possibility here?
But TTP would be first priority, and a plasma exchange with FFP has mortality benefit in this case.
Can it be septic shock with multi-organ dysfunction?
Yeah, it can be, but the presentation is unusual. Septic shock.
Yes, because there is no any history of any like
Where
Fever and all that.
pneumonia, UTIs. There should be some source or pyrexia of unknown origin, but for that the history should be a little prolonged. So she received some antibiotics, some painkillers. After that, she presented with these symptoms, and her ANA is also positive. It indicates some autoimmune pathology.
Immunopathology.
Yes. So can anybody enumerate causes for TTP? Why? What is the etiology for TTP? And what is the basic pathology in TTP? Why there is a thrombosis and thrombocytopenic purpura? So it's a microangiopathic hemolytic disorder.
Third.
So platelets are low, but still patient has a thrombotic tendency. So that's why she presented she might have presented with TIA like features or maybe stroke like features. Because what happens here in the disease process, there is a deficiency of which factor? Adams 13. So Adams 13 is needed. This is the protein that is needed to cleave Wolff-Windbrand factor multimers. So generally these Wolff-Windbrand factor multimers, if they are not cleaved, they cause thrombosis in microvessels. So all the organs, including brain, kidney, skin, all the organs might get involved because of the blockage by this Wolff-Windbrand factor multimers, because that is not cleaved due to the deficiency of Adams 13. But again, it's not a very specific test because Adams 13 factor might be low in many other situations as well. Like in sepsis, in pregnancy, these levels might be low. Even the pregnancy can present first time, primary can present as a TTP, because pregnancy uh, can cause immunogenic phenomena and autoimmune phenomena and can cause TTP. But the TTP has very low Adams 13 level, less than 10%. For rest of the situation, levels might not be that low. It might be 15, less than 15, less than 20, but very severely low levels are found in TTP. So it's not very specific test, and you cannot wait till the results come. If clinically you think patient behaves like TTP, because it's a medical emergency, you have to go for plasmapheresis or at least plasma transfusion. So plasma exchange with FFP has a mortality benefit, it's true. Low platelets favors the diagnosis of HUS, it is false. Though platelets are low, the differentiating feature between HUS and TTP is in HUS, kidneys are involved more. So creatinine is mostly more than 2.5, and most of the times patient might need dialysis. On the contrary, in TTP, creatinine will be less than 2.3. Most of the times they will not need dialysis, they will be non-oliguric. But the platelets are very, as compared to HS, they are uh, quite low. And as I said, low Adams 13 level is a specific test. It's not true because there are other conditions in which the levels will be low. But yes, the severity of low Adams 13, it again points out towards TTP. So mixing studies help establish diagnosis of congenital TTP? No. Congenital TTP means there is a mutation in Adams 13 gene. But most common pathology or etiology is acquired TTP, which is because of autoantibodies that are produced against Adams 13. And that's why plasmapheresis has a role which removes these autoantibodies. At the same time, by giving FFP, we replenish the Adams 13 level so that it will not allow multimers, von Willebrand factor multimers to form and block the smaller vessels. So mixing study, it helps distinguish between acquired causes of TTP, because as we know that whether it is clotting factor deficiency versus inhibitor to the clotting factor. In a similar way, it helps distinguish acquired causes of TTP and not the congenital. Congenital cause needs genetic testing.